Hello. Next up is the caustics. I want to talk to you about acid burns and alkali burns. If you remember a little basic pathophysiology, the acid burns cause a coagulation necrosis. And the base burns, the things that are base or lye, cause liquefaction necrosis. And if you recall, the base is worse because it keeps on dissolving and going deeper and deeper into the tissue that's exposed. Where the acid exposure coagulates the superficial surface of the skin, and the acid cannot get to the deeper layers of healthy tissue. So let's take a couple of cases. Let's take this first case as a 40-year-old chemist who splashes acid and base into his eye. All right, what's the next best step in management? Let's pretend he walks into your clinic or your ER, they tell you, and he's complaining of severe eye pain. It's red, it's tearing, it hurts, he's in a lot of pain. He says, I splashed something in my eye, I splashed something in my eye. Is the next best thing to check his HMO insurance card? Is the next best thing to get his middle initial and his date of birth? Or is the next best thing to check the visual acuity? That could be. Or is the next best thing to treat the patient? Well, let me give you a hint. On boards, as soon as you have enough to treat a patient, treat the patient on step 2, step 3. So, as soon as he says there's a chemical in my eye, you put this man, lay him back, and you start irrigating the eye. All right? He splashed some liquid chemical in his eye, you start to irrigate. And that is the first best step of treatment. How long do you want to irrigate for? Well, if it's an acid or a base, you want to irrigate for at least as long until the pH of the eye returns to normal. So I would irrigate for 15 minutes. Yes, you can send a coworker off to find out the name of the chemical. But after irrigating for 15 minutes, then I would let the patient relax for a minute, let him form his own natural tear, and test the tear with pH paper. If the pH isn't 7, I know I need to irrigate some more. Okay? And keep doing that till the pH is normal and the burning is stopped. Okay. After the eye is irrigated, then I assess for damage. After I stop the burning, I assess for damage. I could do visual acuity, a thorough examination of the eye. I could use fluorescein, a drop of orangey fluorescein and a blue light to determine if the cornea has been burnt or injured. If the cornea is burnt or injured, I'm going to use antibiotic drops to prevent infection. So if you do have a corneal injury, this is a time for antibiotics topical on the eye, antibiotic drops or antibiotic salve. For pain management, while the patient's in the clinic, I could use a drop of topical anesthetic. However, when the patient goes home, they cannot go home with a bottle of eye drops that are Novocaine, Opthane. When the patient goes home, they need to be sent home with pills like Vicodin, some type of narcotic for pain control. Now, what if someone gets an acid or a base on their skin and it's not a liquid, it's a powder? If someone spills liquid on their skin, liquid acid, you just put your arm under the water for at least 15 minutes. What if they spill hydrochloric acid powder on their skin? If this is the case, you want to whisk off, brush off as much powder as you can before you add water, before you put the arm under the sink and faucet. Because once you put the arm under the water and it hits this acid powder, it's going to spread the area of the burn and make the burn much worse. Okay? So if it's a powder, acid, or base, brush it off first, then irrigate. Now let's talk a little bit more about the person that ingests an acid or a base. This is usually a suicide attempt. And the key issue here is you really don't want to make the person vomit, because that will bring up the acid or the base and reburn the esophagus. So the theory here is just to dilute the acid or the base with a little bit of water. Have the patient take some sips of water. If the patient has burning in the mouth, like they have oral burns or mucosal burns here, sure, have them take a lot of water, hold it in their mouth, swish, and spit. So if there's oral burns, have them swish and spit and certainly wash off the face if there's anything on the lips or cheek on the outside. But for the burn that's in the esophagus, you just take a few sips of water. That's it. You never try to neutralize the burn. In other words, if you drank a strong acid, you don't give the patient a base to drink. If they drank a base, you don't give them a strong acid, because what can happen? What will happen? If you add an acid in the base, you get an exothermic reaction. I knew there was a reason we took inorganic chemistry to be physicians. That liberates heat, and you'll get a thermal burn on top of the chemical burn that's already present. So neutralizing acid and base is always the wrong answer. Who has a severe burn of the esophagus? These are going to be people that have pain on swallowing and have abdominal pain to palpation. All right? Those are people, if there's any suggestion of a serious esophageal burn, that need to have endoscopy performed to assess the degree of burn to their esophagus. We already mentioned that charcoal is a no-no for acid and alkali burns. I want to tell you now that steroids and antibiotics are also not given prophylactically for acid or alkali burns of the esophagus. Don't give steroids. Don't give antibiotics. If the next day the patient develops mediastinitis and 104 fever, then you'll give antibiotics, but not prophylactically. So if there's an esophageal burn, do we want to put an E-wall tube in? Do we want to put a nasogastric tube in? No. Don't put any big tubes down there. Let the endoscopist do that. Okay. Do you want to do a chest x-ray to look for any signs of free air or perforation for the esophagus? That might be reasonable. You could do that if you think. If you like, that would be fine. Well, that's the approach to acids and alkali.